Spinous SAQ82 Down syndrome. A 9-year-old child with Down syndrome is scheduled for an adenotonsillectomy. A. List airway and respiratory, cardiovascular and neurological features of the syndrome relevant to the anaesthetist. Airway and respiratory, atlantoaxial instability, care with neck manipulation, especially on extension, cervical spine synostosis, aka Klippel-Feil syndrome. This limits neck extension and may make intubation difficult. Cervical spondylosis may occur. OSA, which may be caused by craniofacial abnormalities such as macroglossia, narrow midface, oropharyngeal hypotonia, micrognathia, small mouth, short neck, and adenotonsillar hypertrophy. Incidence of OSA 50 to 75% in Downs. Mask ventilation may be challenging. Subglottic or tracheal stenosis may require smaller ETT size. There is increased incidence of lower respiratory tract infection due to hypotonia, GE reflux, and reduced immunity. CVS, increased risk of congenital heart disease such as atrioventricular canal defects, atrioseptal and ventricular septal defects, PDA and TOF, pulmonary hypertension with or without associated cardiac lesions. Conduction defects may follow repair of congenital lesions. Valve abnormalities in adulthood includes mitral valve prolapse and aortic regurgitation. Neurological issues includes hypotonia, care with positioning, epilepsy, intellectual impairment. This affects consent and cooperation. Degree of cooperation varies. Ocular and acoustic impairment is common and may make communication difficult. Examples include squints, cataracts, severe refractive errors, glaucoma, smaller eustachian tubes leading to middle ear effusions, and accumulated earwax leading to conductive deafness. There is increased sensitivity to sedatives and anesthetics, reduced MAC requirement, possibly due to reduced central catecholamine activity. Post-op agitation may occur. B. What are the general principles involved in pre-op, intra-op, and post-op management of this patient with Down syndrome? Pre-op. Full patient assessment involving parents or carers. History and examination of the patient is required to identify associated congenital problems prior to anesthesia. Explanations and consent appropriate to patient's understanding and sensory function. Arrange ward visit and opportunity to meet staff to help manage anxiety. Presence of parent or carer will be greatly reassuring for the child. Airway. Assess for airway difficulties associated with Downs. Consider radiological assessment of cervical spine if atlantoaxial instability is likely. Respiratory. Assess for possibility of OSA, especially considering that the patient requires an adenotonsillectomy. Symptoms of OSA include snoring during sleep, daytime somnolence, behavioral changes and poor concentration and inattention at school. Patients with severe OSA are not suitable for day case surgery. Assess for symptoms and signs of lower respiratory tract infection. Consider anti-sialagogue pre-medication. Antimuscarinics also help attenuate a bradycardic response during induction. CVS. Assess exercise capacity, history of cardiac defects and corrective surgery, clinical features suggestive of congenital heart disease. Examples include failure to thrive, breathlessness and fatigue on exertion, unexplained syncope or fainting, recurrent respiratory infections, tachycardia, tachypnea, cyanosis, clubbing, respiratory distress, cardiomegaly, hepatomegaly, heart murmur, palpable thrill, and decreased or absent femoral pulses. Characteristics of pathological murmurs includes all murmurs associated with cardiac signs or symptoms, all pansystolic and diastolic murmurs, late systolic murmurs, and loud murmurs, those associated with trills or continuous murmurs. ECG. Right heart strain on ECG may be indicative of pulmonary hypertension. Investigate with echo. Cardiac conduction defects may present following repair of congenital lesions. Patients may be on pharmacological therapy for arrhythmias or pacemaker. Echocardiography should be obtained in all children with Down syndrome. Discuss with cardiology or cardiothoracic team if necessary. Topical LA such as AMLA or Amatop to be used in preparation for IV cannulation. Neurological. Atlantoaxial instability. Symptoms of possible neck problems include neck pain, limited neck mobility or head tilt, change in gait pattern, clumsiness, abnormal neurological reflexes, abnormal sensation or presence of bowel or bladder dysfunction. Consider radiological assessment of cervical spine if atlantoaxial instability is suspected. This is diagnosed by identifying increased distance between the posterior border of the arch of atlas and the anterior border of the odontoid peak on lateral flexion and extension radiographs of the cervical spine, also known as the atlantodental interval, ADI. In more than 8 years old, ADI should be less than 3 mm. In less than 8 years old, ADI should be less than 4 mm. There is no consensus in literature to suggest whether every patient with Down syndrome should be screened radiologically prior to an anesthetic or surgical procedure. Indications for cervical spine radiograph before elective procedures includes sign and symptoms suggestive of cervical cord compression, difficult laryngoscopy anticipated, and surgery requiring the neck to be placed in non-neutral position for prolonged periods of time. An unstable spine should be considered for surgical fixation prior to other surgery. Sedative pre-medication. If the child is anxious and uncooperative, consider sedation with oral midazolam or temazepam. Occasionally, IM ketamine may be required. Pre-medication should be used cautiously in patients with severe OSA. Endocrine. Consider thyroid function and blood glucose testing. GI. Assess GE reflux. Pre-medicate with proton pump inhibitor and plan for RSI if indicated. Intraoperative. Ensure carer or parent accompanies the child to the theatre. Try to gain the child's trust and cooperation. Have a discussion with the parents or carers regarding the mode of induction of anesthesia and any associated procedures, such as the use of analgesic suppositories. Involve play specialists if required. Monitoring. Routine monitoring should be used as for any other case. As a minimum, include ECG, pulse oximetry, EtCO2, blood pressure and temperature. Consider weight and size when calculating drug dosages and size of equipment used. Airway and breathing. Consider the need for difficult intubation equipment. Incidence of airway obstruction 1.8%, incidence of difficult intubation 0.54%. Skilled assistance should be present, especially if inhalational anesthesia is chosen, to maintain airway while IV access is obtained. Skilled assistance enables management of the challenging airway, airway obstruction, and bradycardia on induction. Intubate the patient, possibly with RSI. Care for the neck during laryngoscopy and intubation is necessary. Avoid forceful flexion and extension of the neck due to possibility of atlantoaxial instability. Table tilt may be preferable to neck rotation. Have a range of tube sizes available. Smaller tubes may be required if subglottic stenosis occurs. Oropharyngeal airway may be required to facilitate mask ventilation. Bronchospasm is a possible complication. CVS. IV cannulation may be challenging due to the tendency of obesity. Gaseous induction with sevoflurane will be helpful. Down's patients are prone to bradycardia after induction. Ensure availability of atropine and glycopyrrolate. Perceived sensitivity to atropine may be erroneous and is of little clinical significance. Advantages of atropine includes chronotropic effects, which may be useful in the presence of low plasma catecholamine concentrations, and anti-sialagogue effects may attenuate perioperative respiratory complications. Avoid hypotension in order to preserve spinal cord perfusion. Avoid factors that increase pulmonary vascular resistance. ECG monitoring due to possibility of arrhythmias. Neurology. Care with positioning due to ligamentous laxicity and possible atlantoaxial instability. Care with neck movements. Ideally, the head and neck should be neutral position. There has been a case report where ADI has been normal prior to surgery, but post-operatively the ADI has increased, requiring upper cervical fusion at a later date. Avoid long-acting opioids and consider lower MAC requirements. Use of multimodal analgesia and opioid-sparing analgesia, and regional analgesia as appropriate. Infection and immunology. Scrupulous attention to asepsis due to increased risk of infection. Patients with Down syndrome have impaired immunity. Regarding infective endocarditis prophylaxis in general, guidelines have not been in agreement about antibiotic prophylaxis in the prevention of IE. The European Society of Cardiology and American Heart Association have each restricted prophylactic antibiotics to those patients with highest risk of adverse outcomes, and NICE advised against prophylactic antibiotics altogether. The exception to this is patients at risk of IE who are undergoing GI or genitourinary procedure at a site of suspected or proven infection. There is no global consensus for patients traditionally considered high risk. According to NICE, high-risk patients includes previous IE, acquired heart valve disease with stenosis or regurgitation, patients with heart valve replacement, hypertrophic cardiomyopathy, or structural congenital heart disease, excluding isolated ASD, fully repaired VSD, fully repaired PDA, and closure devices that are thought to be endothelialized. General recommendations: antibiotics indicated for surgical procedures should be given as normal. For infected surgeries in patients at risk of IE, appropriate antibiotic prophylaxis should be administered. In patients at high risk of IE, the decision to provide prophylactic antibiotics for dental treatments should be made by the treating clinician after discussion with the patient. Administration of antibiotics is not risk-free. Local protocols should be followed. Preventive measures to reduce the risk of IE includes maintenance of oral hygiene, timely treatment of infection with pathogens that causes endocarditis, antibiotic prophylaxis prior to invasive dental or invasive oral procedures. Antibiotic prophylaxis for surgical site infection reduces the risk of surgical site infection, which may also reduce the risk of subsequent endocarditis. An example is antibiotic prophylaxis prior to cardiac surgery. Closure of PDA or VSD. The preferred regimen is oral amoxicillin, adult 2 grams, children 50 mg per kg. Post-op. Patients should be observed closely in the recovery room until full recovery from anesthesia. The presence of parents or carers can help to avoid disturbances in the post-op period. Airway and breathing. Hypotonia may affect the ability to maintain airway. The patient may require simple airway maneuvers such as head tilt, chin lift or jaw thrust, or appropriate positioning to the lateral position to maintain patency of airway. If atlantoaxial instability is suspected, only jaw thrust should be used. Airway adjuncts such as oral or nasopharyngeal airway may be helpful. There is risk of OSA. The patient may need CPAP, overnight oxygen saturation monitoring and close nursing observation. Post-extubation stridor or croup may occur. Treatment is with humidified oxygen, adrenaline and IV dexamethasone. The dose for adrenaline is 400 mcg per kg, max dose 5 mg. ECG should be monitored and it should be stopped if heart rate exceeds 200 per minute or if arrhythmias are seen. The dose for IV dexamethasone is 250 mcg per kg, followed by 100 mcg per kg 6 hourly for 3 doses. Monitor for CVS stability. Neurology. There is predisposition to post-op agitation, which may jeopardize IV lines and dressings and even fixation devices. If this occurs, sedation may be required. However, sedatives and opioids carry the risk of airway obstruction and respiratory depression. Prolonged recovery stay and higher intensity nursing care may be required. Regarding post-op pain relief, post-op pain assessment can be challenging due to intellectual impairment and communication difficulties. The parent or carer who knows the child well may be required to assist in pain assessment. Avoid long-acting opioids, especially if the patient has OSA. Regional analgesia may be challenging in obese patients with behavioral difficulties. However, benefits includes avoidance of respiratory depressant effects of opioids and improved compliance with physiotherapy. Monitor for signs of spinal cord compromise and investigate promptly. Any new neurological abnormalities should be promptly investigated. Immunology. Monitor for signs of post-op infection, especially for pneumonia. Alert parents and carers to signs that they should be aware of. Additional Q&A. September 2016. The answers for Part A and C have been discussed in the previous question. For Part B, which asks what are the potential problems during induction of anesthesia and initial airway management in a 5-year-old child with Down syndrome scheduled for adenotonsillectomy. Problems includes communication difficulties and problems related to airway management. It may be challenging to establish good communication and rapport with this child. Parents, carers, and play specialists may be required to assist. Problems with airway management includes increased risk of GE reflux, which may necessitate RSI, increased likelihood of difficult mask ventilation due to craniofacial changes of Down syndrome, and adenotonsillar hypertrophy. The patient may require oropharyngeal airway. There is possibility of difficult intubation due to subglottic stenosis. Smaller endotracheal tube sizes must be available. Neck extension may be limited by Klippel-Feil syndrome or atlantoaxial instability. Hence, video laryngoscopy or a sleep fiber optic intubation may be indicated. Additional information. Down syndrome is the commonest chromosomal abnormality and is named after John Langdon Down, who described the syndrome in 1866. 95% of patients with Down syndrome have trisomy 21, 4% have chromosomal translocation, and 1% mosaic trisomy 21. Incidence is 1.5 per 1,000 live births. 1 year survival more than 90%. 45% survives to 60 years old. Maternal age is a risk factor for Down syndrome. Multi-organ involvement in Down syndrome. Generally, patients have low birth weight, small for age, generalized hypotonia and lax joints, flat occiput, short neck, small low-set ears, flattened nasal bridge with mid-face hypoplasia and protruding tongue, prominent epicantic folds, upward slanting eyes, brush-filled spots, single transverse palmar crease, larger than normal space between the big and second toe. Respiratory, recurrent respiratory tract infection, subglottic stenosis, tracheal stenosis, enlarged tongue, enlarged tonsils and adenoids, and OSA. Cardiovascular, congenital heart defects such as AVSD, VSD, PDA, ASD, and TOF. Pulmonary vascular disease may occur due to isomangus. Pulmonary vascular disease may be due to chronic hypoxemia secondary to repeated pulmonary infections, or hypoventilation due to muscle hypotonia and OSA, or defect in pulmonary capillaries. CNS manifestations includes developmental delay, mental retardation, microcephaly, epilepsy, post-op agitation, Alzheimer's, hypotonia, reduced MAC requirement, increased sensitivity to sedatives and anesthetics, ocular and acoustic impairment as mentioned previously. Musculoskeletal, atlantoaxial instability, possibly due to abnormalities in C1 vertebra, C2 vertebra, and laxity of transverse ligament. Spinal cord compression is seen in 2%. Cervical spondylosis, Klippel-Feil syndrome. There may also be laxity of other joints, general poor muscle tone, and short stature. Endocrine. Down syndrome is associated with hypothyroidism in 50%. GI. GE reflux, esophageal atresia, duodenal atresia, Hirschsprung disease, gallstones, and celiac disease may occur. Hematology. Polycythemia is frequently seen in neonates. Down syndrome is associated with acute lymphoblastic leukemia, acute myeloid leukemia, transient abnormal myelopoiesis, and lymphomas. Immunology. There is impaired cellular immunity, abnormalities of T cells, B cells, gamma globulins, and neutrophil function. Other associations with Down syndrome includes obesity, difficult peripheral venous access, and dental problems. These are my references. Thank you.